First of all, we've got from our first speaker is John Billings from GMC, Assistant Director of Revalidation, and he's going to give us chapter and verse.
Oh, that was my introduction. Oh, I see.
Yes, it is. Yes.
Yes, thank you very much, Mike. Good afternoon, everyone. I'm very pleased to be here. I'm wondering if is it easiest if I just sit down, or do you want me to stand up? What do you think? Yeah, it's a small enough group. We can. I've got some slides, as you'd expect, just to kind of structure the discussion a bit. I think, given the size of the group, if there are questions that crop up, then we can pick those up as we go. But obviously, take those at the end if that's easier with you. I mean, I think from my point of view, I have the benefit of working in the only kind of UK-wide body really that's involved in revalidation in the terms of delivering it, and that leads me to be literally all over the country speaking to groups of responsible officers and doctors and others working with this. And I think what I get the sense of is what I would really call a movement across the system to think about how to use revalidation, if you like, as a lever, to think about how to improve clinical governance and the environment, the governance environment in which doctors operate, and obviously appraisal and so on is part of all that. And I think the scale of the effort that's going on across the system really only becomes apparent to those few of us that get to go across the whole system and see it. So I think whilst yes, there have been people working through the detail and thinking about what does it mean for us, I think most people are now getting through that and thinking about how do we use this as an opportunity to drive the quality agenda in our own context. And I think with that in mind, I think revalidation is turning out to be quite an important piece of regulatory policy because of the kind of ripple effect that it's having on a whole raft of other issues within the environment in which doctors operate. So I think what I would like people to think about, before going into it in the detail, is to think about how this can be used as an opportunity in my context to drive improvement and quality in my setting, and not to get too hung up on the technicality of the process. The process in its essence is pretty simple, pretty straightforward, when you stand back far away enough from it. And I just encourage people not to get too hung up on the detail, but to think about the opportunity that it presents. And with that in mind, I mean, I always like to emphasize, what revalidation is. It is and it should be part of a wider system to drive improvement, across the context in which doctors are practicing. And clearly, the practice of doctors is incredibly diverse, and that's why revalidation has been defined and described inevitably in generic terms. And it's then for doctors in their context to interpret that. And that's where some of the discussion and the debate happens, where the confusion and consternation, as you put it, comes from, is people think about how do I make this work in my setting. In most cases, the answer is, well, there's a way of working through it. And I think using it as that lever to drive improvement is an important principle that we try to emphasize all the time. The second thing is it's really trying to address the historical kind of problem, if that's the word, but of doctors once they've gone into specialist practice or moved out of training, that have becoming to some extent isolated, operate and reliant solely on their own professional kind of principles, if you like, to drive improvement and to identify ways of improving, and also to be aware of when they may be running into difficulties. And that's very difficult when you're on your own and not part of a system. So revalidation is about bringing medical practice into some kind of structured, governed process. That gives doctors a framework to create impetus around their own improvement, but also allows them as individuals and people with them to potentially identify problems sooner than may currently be the case. And of course, the additionality, the thing that revalidation brings, is an additional positive confirmation that doctors are operating within the professional framework set out by good medical practice, rather than historically, we know about people who run into problems, serious problems, because they find their way to the GMC, potentially. That's a very small number in proportion to the totality of the medical population. And what this does is brings a periodic positive confirmation that that doctor continues to practice in accordance with the values and principles that the regulator sets out. And what it isn't, again, to emphasise, is a test or an exam or a point-in-time assessment. It's not a new way to raise concerns about doctors. There are pre-existing and well-established mechanisms for raising concerns about the fitness to practice of doctors, and those aren't changing. The threshold for fitness to practice isn't changing. All that remains the same. So this isn't creating a new pathway, if you like, for dealing with problems. And in the context of appraisal, where that happens, it's not the purpose of appraisal. Appraisal is a vehicle for revalidation, but clearly there are much wider uses and applications of the concept of appraisal in the employment and other contexts. And so, you know, revalidation, if you like, is an output from that. It's not the purpose of it. Now, in terms of the process, again, this is heavily simplified, but essentially, it's the left hand in your view box, I think, is where the main business happens, and that's where the focus needs to be about ensuring that the doctors are plugged into an appraisal program, that they are part of that system that I talked about, that structured process, and as I'll say in a moment, the GMC has specified, has created a specification for that process, which needs to be followed. But that's that needs to be the real focus of the thing. Periodically then, the responsible officer or the person acting as a responsible officer for that doctor will essentially verify that the doctor is in that process and that nothing untoward or of concern has come out of that process, and that the doctor has done what the regulator has asked them to do as part of that process. And on the basis of that verification, they recommend then to the GMC that that doctor's license to practice should continue. The license to practice doesn't run out. It's not time limited. This is a confirmation that the license continues unchanged. And then, having received that recommendation, the GMC will make sure that there are no potential barriers or impediments to continuing the license. So there's nothing that the GMC knows, if you like, that the responsible officer may not have been aware of, although that shouldn't happen in practice. But if there was anything, and it could be as kind of mundane as the doctor hasn't paid the fees, but if there are no impediments and no reason, if you like, not to accept the recommendation, then the GMC will renew or revalidate, as we call it, that doctor, which means in practice their license carries on, and they'll then have another revalidation date set for them, which will be 5 years hence from the day that comes. So that's the sort of outline of the process. As I've said, we've specified, the GMC has specified what the content of the appraisal mechanisms are and what the doctor needs to do in terms of collecting information to support that appraisal process. So the circles in the middle are really just summarising the fact that the appraisal for the first time is intended to be on the whole practice of a doctor. So the revalidation, the appraisal that feeds into revalidation needs to incorporate a discussion about all practice that the doctor is involved in. So in doctors, which in many cases, where they're operating or practicing in a number of different settings, information from all of those settings needs to come into that appraisal discussion, and therefore the intention being that there are no blind spots, if you like, in the doctor's practice that aren't subject to some kind of structured review and discussion. We've then said, as part of that, there are particular types of information we think the doctor should be collecting in firstly helping them to reflect on their practice, and then helping them to support a discussion with their appraiser. And there are two important pieces of guidance which are on the GMC's website, set out in the two grey boxes there. The first one on the top right sets out what we call the good medical practice framework for appraisal. It's about saying, well, what does appraisal need to look like in order to fulfil these requirements? And the box in the bottom left represents guidance that we've set out about supporting information. You know, what information does the doctor need to bring to that? Again, these are generic. requirements necessarily, because the GMC can't define, to the nth degree the practice of every doctor, because there's a huge diversity in practice, and therefore that generic guidance has to be interpreted into the particular context of doctors. It's framed as a set of guidelines or guidance. It's not framed as if you like, a absolute doctrine that has to be followed. And where there is reasonable, challenge around certain aspects of it, provided there's a clear discussion between the doctor and the appraiser that says, look, this particular thing clearly doesn't work in your context. What you could do instead might be X, Y, and Z. And we might talk about what that might look like as we go along. So we've set out, this is specifying what needs to happen, specifying the appraisal, specifying what the doctor needs to do in terms of gathering the information. And in terms of this sort of what we sometimes call the rollout or the pickup phase, where we're starting from naught and going to 230,000 doctors with a license having been revalidated. That clearly can't happen just overnight. There has to be some kind of pickup phase. And obviously we have to start from somewhere. We can't wait for everyone to have 5 years worth of appraisal, for example, that meets these requirements. We need to be able to bring people into the system sooner. And bearing in mind that the focus is, as I said at the beginning, ensuring that the doctors are in a process as opposed to ticking off particular things. What we've done is we've specified the minimum requirements for what we refer to as readiness for a doctor to have a recommendation made about them in this initial phase. So if a doctor has been participating in annual appraisal, which has good medical practice as its focus and covers all of their practice, if they've completed at least one of those appraisals and had them signed off by both the doctor and the appraiser, and if within that the doctor's shown that they've gathered all the supporting information, and made reasonable efforts to do all that, those are the minimum requirements. And if you've got a doctor that meets those requirements, then at this stage they're ready to have a recommendation made once revalidation commences. And this is a way, firstly, of being pragmatic about saying, we can't all start from a perfect position. We have to work up to readiness, but it's also a way of avoiding doctors being, if you like, artificially forced into a process that they can't meet the requirements of from the outset. So it's setting out what is the minimum that's required before a responsible officer or someone acting as a responsible officer can make a recommendation to the GMC. What's required for revalidation is that an appraisal needs to happen which encompasses the totality of your practice.
Right,
so
you're going to have this one appraisal that encompasses everything.
Yes.
Right.
And recognise that's a new thing, that's an innovation, and people need to work towards that and work through the practical implications of that. That's why there's a pickup phase and people need time to get into that. But we can come back to how that might happen in a minute. We've talked about the supporting information, but what I would say is there are some qualifications around the supporting information, which is that what some people have said is, look, I can't gather information about my personal practice. I operate as part of a team. I'm in a surgical team or whatever it might be. I can't get information that's just my information, and that's absolutely a valid point. And so what we've said is that team-based information is completely valid in this context, provided the doctor uses it to reflect on their personal practice and that they use the team information to focus on their practice.
Have you gone to the other extreme, and that is the independent one-man band as opposed to working in a team? Because that's where I am. And it strikes me that a lot of this is just designed to drive me out of business, put it that way, and resign, because that's the way I feel about the whole thing.
Okay, well, it certainly isn't designed to do that. So, we can talk about that as well. What I would say is that, if you are a one-man band, then you know best the information that, if you like, emerges from your practice that you can capture to support this process. And you're not dependent on others to find that information.
Well, I am, because you put in there feedback from patients, feedback from other professionals.
But I also said that where that's not immediately obviously straightforward to do, there are other consumers, if you want to put it that way, of your practice. You know, there will be other people on the receiving end of your practice. And what we've said, what our guidance says, is that we should asking doctors to take a broad view of how they get you know, input, feedback from others, from people, so that it's not them just coming to a view on their practice, that they are taking the views of others and people that they deal with, clearly in the sort of, in a context which isn't the kind of what you might call the traditional patient-doctor relationship. Then we need to take a more kind of creative view about, you know, how do we get a view about our practice.
So do you mean then instead of colleague, you'd say the person, the company you provide the service to? That's absolutely feedback from colleague would be.
I think it's important to focus on the bit on, and it goes back to the point I made at the beginning, is that people, understandably, have become very kind of focused on the process. What do we need to do? Tell us what we need to do. And that's absolutely fine. I think we also need to bear in mind, though, what are the behaviours that this is trying to encourage and promote. And the behaviour it's trying to encourage and promote in this context is reflection and if you like, breaking down of isolation, that, you know, that a judgment about your practice is resting solely on your shoulders as an individual practitioner, that it's drawing other people into that, or other recipients of your practice, if you want to put it that way, into the discussion. And if the main recipient, if you like, of your practice is a company, then I think finding a way to get some kind of feedback from them, you know, is completely legitimate. And if you're not dealing directly with patients, then who can you get a view from about your practice? I think the other point to make about this, going back to your point, this is just driving me out of business, is that this is intended to be proportionate. It's intended to be based on what you actually do. It's not intended to create artificially activities purely for the purposes of revalidation. It's meant to say, you know, the regulator has set out a framework for you as a practitioner to kind of interpret that into your context and in discussion with your appraiser, and come to a view about the most appropriate way to do that in your context. So there's a question at the back.
Yeah, I mean, the principles are all very laudable and things like that. I'm a responsible officer for a designated body. I've been so inundated with information, emails, hoop jumping exercises by the SHA, it's unbelievable. We've had an in-house appraisal process as an example. I'm now told that's not good enough for me, I have to have it done externally. They've provided a list of appraisers who've had top-up training. We're having to send two of my colleagues off for appraiser training because what we've done already is not good enough.
They say.
They say.
The NHS says.
NHS says. It's
well, I mean, there is a slight paradox in this system, which is that the responsible officer regulations, which are owned by the Department of Health in the 4 countries, in England are being, if you like, the statutory responsibility flows out currently through the SHAs. So they're given a statutory responsibility to oversee the responsible officers across the patch, not just in the NHS. So they're operating in that context as a statutory, in a statutory role which transcends the NHS, the private sector, the commercial sector. Because this is a new system, and you know, there is understandably a view that there will be a whole variety of practice out there. One of the issues about variability could be the mechanisms for appraisal. So some of the SHAs have said, look, we need to try and find a mechanism of putting some parameters around what those appraisals look like, so that I, as the responsible officer, in the case of London, Andy Mitchell, can at least have some kind of assurance that when I get a recommendation from this responsible officer, it's based on something that's in the similar territory to what's happening with someone else. I don't think it's the case that that there's expected to be exactly the same, because again, going back to my point, context has to be reflected. But the principles are that there should be some commonality, some consistency across the system, so that when one doctor has a recommendation made that their licence should continue, it's at least broadly based on a similar basis. Now, I do recognise that in the setting up of a new system, that a certain amount of hoop jumping, as you've put it, you know, has emerged from that. But that's I think that's a feature of a big new system being created, and this brand new functions that responsible officers and now have. And I think it is true that there's a lot of, if you like, effort and so on going into that. But I wouldn't interpret that as a kind of pointless hoop jumping. It is about trying to bring effect to a new statutory framework that the RO for the SHA is operating within, and that you as ROs and the people that you work with are also bringing themselves into.